Hi, good evening, good morning, good afternoon, everybody. I'm Mohammed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France, and it is my great pleasure and honor to welcome you to this new webinar by the International Academy for Clinical Hematology. And our guest speaker today is a very distinguished master in this field, namely Dr. Jim Bussel. Dr. Jim Bussel is an emeritus professor of pediatrics, medicine, and obstetrics and gynecology at Weill Cornell Medicine in New York City. He graduated from Yale University, attended medical school at Columbia College of Physicians and Surgeons, and did his residency in pediatrics at Cincinnati Children's Hospital, but also his fellowship in pediatric hematology and oncology at Weill Cornell and Memorial Sloan Kettering. He has been in the field since 1981, and his clinical and research focus have been largely in immune thrombocytopenia and fetal and neonatal autoimmune thrombocytopenia. He has published more than 400 peer-reviewed manuscripts, including 6 as first or second author in the New England Journal of Medicine. So, as you can guess, we have here today with us a true master in this field. And we're very grateful here at the ICH to Dr. Bussel for sharing his knowledge and providing us today an update about the current development in ITP. So without any further delay, I would like to invite Dr. Bussel to give his lecture, and we will take a few questions after the lecture. So please do not hesitate to share your questions, your comments, your whatever you'd like to say to Dr. Bussel, and we will meet again in around, let's say, 35, 40 minutes, I guess. So, Jim, the floor is yours.
It is my pleasure to talk to you today about ITP. While this is a relatively common disease, there are many subtleties and new developments in it, and I'm going to try to review those. These will include issues with diagnosis, refractory patients, and touch on some of the novel therapies. My name is Jim Bussel. I'm a professor emeritus of pediatrics at Weill Cornell Medicine in New York. I consult for a lot of different companies that are involved in the ITP space in one way or another. They're listed on the slide. As you, I'm sure, know by now, ITP, unlike when I was in medical school and fellowship, is not solely a thrombocytopenia caused by increased peripheral platelet destruction, but also by inadequate platelet production. While we know in general how that can happen, antibodies, T cells, etc., we don't know in any given patient usually what is the predominant mechanism, and this is a theme we'll come back to. There are obviously many mechanisms as highlighted here, including the concept that was first put forward by Doug Seens 20 years ago about the idea of epitope spreading and worsening of disease with more antibodies against more platelet antigens. On the other hand, we also know that many patients will get better over time, even adults with ITP, and therefore this remains quite murky, though we understand it well in theory. Because there are so many different actors in this autoimmune disease, as in other complex autoimmune diseases, you can see here on the right side of the slide under treatment MOA that many different treatments could be used, and typically they all have advantages and disadvantages, and we'll touch on some of them later. One thing that's very important is how little we can do and do diagnostically at presentation. And for the IACH journal, in 2018, we published an article contrasting two cases of thrombocytopenia who went to the emergency room with bleeding, and one had leukemia and one had ITP. If we first look at the one with leukemia, they will have an extensive workup. There will be flow cytometry, there will be histochemistry, there will be cytogenetics and genomics in various forms. And in addition, they will, of course, have a bone marrow to aid in the diagnosis. In contrast, a patient with ITP, the only consensus, as we'll come back to, is that they have a CBC and that we look at the smear. If we have this leukemia patient, they will be divided into one of 10 to 20 groups, and each of these groups will have different risks, different courses, different outcomes, and each of these groups will have a different treatment protocol. And once the type of leukemia is identified, even if it's in a study or if it's not, the treatment will be pretty clear for the next number of years as to what to do: induction, reinduction, consolidation, maintenance, etc. And if there is a relapse, there may be some indication of how to proceed. And in addition, there will be a considerable amount of information available for monitoring. When do repeat marrows need to be done? Are there any CTs or other tests? What about LPs, etc.? In contrast, take a patient with ITP. They come in, the platelets are identified to be low. Ideally, the other cell lines are normal. There's nothing striking on physical exam, no hepatosplenomegaly, no other findings except for signs of bleeding and bruising. And we'll say, hey, this is ITP. In addition, if the leukemia patient is being treated and, for example, says, I hate being on steroids, it makes me gain weight and I feel crazy, or whatever they might say, more or less in the nicest possible way, they will be told, you have to do this because otherwise we're afraid you might relapse and die. ITP patient says the same thing. I hate steroids. I'm not going to take them anymore. You say, okay, well, we'll try something else. Here are the other options. So the point is, there is much, much less available information on ITP, and that means there's a lot more art and, unfortunately, less science. Clearly, the history of both the patient and the family and the physical examination are important, and also very important is review of the smear. A lot can be gleaned from review of the smear of various types of information. In this patient's case, we have an example of a 20-year-old female who's generally been well. Her history is benign, except recently her menses have been heavy. Her family history, her grandmother has arthritis. She has bruises and petechiae. Maybe she has an oral blood blister. Her CBC has a platelet count of 8,000, normal white count and diff. Her hemoglobin's a little low, but her MCV is small, suggesting that very likely this is either iron deficiency or thalassemia trait. And on the smear, she has some large platelets. Important is inherited thrombocytopenias most commonly have too large platelets. In ITP, we expect some large platelets, but we don't expect them all to be the size of red cells, and we don't expect all of the platelets to be very large. So let's start with some of the possible wrinkles here. Assuming that we think she has iron deficiency and we've put her on iron. What if she is either already on oral contraceptives or you want to use them to reduce the flow of the menses? It's important to realize that estrogen can worsen ITP, but most people don't know that actually progesterone in 3 different studies has been shown to improve ITP and increase the platelet count. So the point here is, if she's on estrogen, it would be ideal to take her off. And if hormonal therapy would benefit her, using a progesterone in one way or another is better. There's a pretty significant overlap of CVID or hypogammaglobulinemia and ITP. It's not that common to have a very dramatic history of infections, although certainly it happens in some cases. But often if a person has ITP, their disease may be a little more complex. And one of the clues could be if she says, well, I had ITP 4 years ago and it resolved with just a course of prednisone, has been fine until just a few weeks ago. We talked here on C about inherited thrombocytopenias, and it's important to find out, did she have a previous platelet count for some reason and was it normal? And if a first-degree relative in her family has low platelets, that's significant. In ITP, in my experience, it's quite rare to have a first-degree relative with true ITP, but it's not uncommon to have cousins or things like that. So it's important to take the history and see what you can find out. Polychromasia here is intended to point out that there's a high retic count. This could indicate Evans syndrome with an autoantibody to red cells and a positive DAT, or it could indicate a microangiopathic hemolytic anemia like TTP or HUS or atypical HUS. If there's splenomegaly, if it's part of the ITP, it's usually barely palpable. So if there's significant splenomegaly, you need to think of other things. Liver function has to be evaluated, consider a lymphoma or a leukemia, and consider a complex case of CVID, among others. What if there are atypical lymphocytes? There are subtle viral infections that can be ongoing where you need to treat the virus to make the ITP better. One example that you might think is too obvious is HIV, but it could be hepatitis C or especially CMV, which can be clinically silent except for either atypical lymphocytes and or minor abnormalities in the transaminases as liver tests. Now, this is a young woman, so you would think about a predisposition to autoimmune disease. So you might want to get an ANA and an antiphospholipid antibody, especially if the APTT is prolonged. Antiphospholipid antibody, as you know, could predispose to thrombosis, especially if you do a very good job increasing the platelet count. And either of these could be a part of a presentation of lupus. What if this is a 63-year-old male? Issues would be different, more likely to be multiple medications and multiple comorbidities. We talked about the possibility of CVID or another form of immunodeficiency. If the MCV is high instead of low, I know you would all be sensitive to the idea that this could be marrow failure and or indication of a malignancy. If there's marked lymphocytosis, mature small round cells, especially if you test and there's increased B cells, this could be a presentation of CLL. We talked about splenomegaly. If there's a history of a DVT or pulmonary embolus and the patient is already on anticoagulation, it's important not to say, well, we can't anticoagulate ever. It's rather important to get the platelet count up faster as opposed to slower and come up with an effective therapy so that anticoagulation can be continued. Now, in a 63-year-old, it's possible to think about a splenectomy, but certainly not in a 78-year-old. And this would influence your treatment decisions and also the differential. Some people would automatically bone marrow either of these patients, others maybe just the 78-year-old, and others just if there's another indication to do it. I don't think there's a set thing yet. If the workup does not leave you feeling satisfactory, what else could you do to help you understand what's going on? Doing genomic testing has not been nearly as useful as it would be in, say, leukemia, but especially if you're looking for an underlying cause, an immunodeficiency, it could be very helpful in that regard, and or in other settings, especially in the older gentlemen, if you're thinking about CHIP. It probably makes more sense to do a panel testing than to do whole exome, but again, depends on the patient, and that's not fully clear. Platelet reticulocyte counts via the Sysmex CBC machine, where it measures the immature platelet fraction, can readily tell you how many platelets are being made. This has not been fully substantiated as a diagnostic tool yet, and I know you know that platelet antibody testing is not either. The most likely tests that could be useful if you find something relate to secondary ITP, and we already discussed bone marrow looking for either a malignancy, myelodysplastic syndrome, or a type of marrow failure. Probably the best diagnostic marker for ITP is a response to ITP-specific therapy, especially IVIG. Certainly, if there's a very good platelet response, there's probably no need to do a marrow. But it's important to realize this doesn't eliminate secondary ITP, and exactly how good a response is a good platelet response, and do you need to see it twice, are probably things that are worth carefully considering. And again, there are no set answers. Finally, it's important to point out cyclic or cyclical thrombocytopenia. You see a patient, they have a low count, it seems like their bleeding history is quite recent. You give a treatment, see them a week later, the count goes way up, you pat yourself on the back, another 2 weeks later, so 3 weeks from diagnosis or 4 weeks, the count's low again, you say, oh, the treatment wore off or the patient became refractory, you give another treatment, the same thing happens. It's important to recognize the possibility of cyclic thrombocytopenia because its management would be totally different. And I would refer you to a recent article in Blood Advances by Jim Zender on mechanisms that he has uncovered recently. Now, what about misdiagnosis? This is taken from a series of 305 patients from the McMaster ITP registry of Donnie Arnold and John Kelton. And the point here is that the Canadian hematologists in this group are very experienced. And nonetheless, after screening out a number of, quote, obvious other causes, they nonetheless had 17% of their patients who were misdiagnosed. Some of the misdiagnosis involved secondary ITP, but most commonly it was marrow failure, and I have to believe inherited thrombocytopenia, which for every 9 or 10 patients with ITP you see, there should be one that has inherited thrombocytopenia. The biggest clue, I think, is the severity of the thrombocytopenia. The more that you have a very low platelet count, the more likely it is to be ITP, and the other features are in accord with that. Coming to secondary ITP, there's a lot of possibilities here, and we've mentioned a number of them, almost all. The one thing I would point out is that there's an incidence of ITP that develops after any vaccination, especially COVID vaccinations most recently. It's very rare if the person hasn't had ITP, although we think in certain cases it uncovers pre-existing ITP. Where it's an issue is if you have a patient who already has ITP, there's maybe a 10% or more incidence of having the count drop dramatically, but it's pretty much always responded to treatment. Very rare that there's any kind of bleeding, and typically it doesn't affect the long-term course. I'm going to skip over these slides. There's a number of publications about it, and I'm also going to skip over the vaccine-induced thrombosis thrombocytopenia issue. Drug-induced thrombocytopenia is possibly common, but it's of importance to note that there are a number of agents that can cause it, but almost all things have been identified as single cases. One of the problems is it's not easy to test for it. There are labs that will do it, but there are false negatives and false positives, and it's not usually in common use. One natural substance to point out is that quinine is not only in tonic water, but is a common therapy for restless legs, and this can be a problem. Given that there's no clear definition or study that defines this, one way to approach it is to change any medications that have been started within the past year, or any medications like the ones on the top of this slide, where it might be common for them to induce ITP. It's important to consider artifactual thrombocytopenia. If there's a question in your mind, if the platelets are said to be low because there's platelet clumping on smear, the textbook way to deal with this is to do a CBC in citrate instead of in heparin. That's not always easy because many machines will not accept samples like that. So possibly an easy way to do it that doesn't require anything special is to do a finger stick and take a drop of blood directly onto a slide, smear it, and look at it under the microscope. Pregnancy and ITP is an important issue. The main things I would tell you is that if you have a difficult case, especially in the third trimester, it's increasingly appropriate to use a thrombopoietic receptor agonist, especially romoplastin. An article coming out in the American Journal of Hematology looked at 186 cases of women who took romoplastin during pregnancy. And in many of the cases, 71, they were on it when they became pregnant. The fact that the neonatal outcomes of any abnormalities were very few and were not uncommon is consistent with the idea that it doesn't seem to have teratogenic effects or lead to other problems. So I think this could be used more, and other treatments like rituximab, cyclosporin, azathioprine, and even splenectomy can be almost entirely avoided. This is consistent also with work from China demonstrating efficacy, but also demonstrating that part of the problem in difficult pregnancy cases may be that they're not making platelets well, and this may be in turn because maybe why treatments like steroids and IVIG become ineffective. This is a published study in Blood in September 20 looking at efficacy and safety of L-trombopag and romoplastin. The article I mentioned looks essentially just at safety, does not look at efficacy, but I think at least I tend to take that for granted. Now, what if you have a patient who's very refractory? We talked about looking at the marrow, could want to look for liver spleen size and or a CT or an MRI for a hidden tumor. Possible there will be blood tests for malignancy that could be done. It's important to remember two very key things here. And I refer you to an article that we wrote in Blood in February 20 about refractory ITP, and also more recently, an article in late 2022 from Italy in Hematologica on refractory ITP. The first thing is that I think a great deal of refractory ITP is refractory because it's not really ITP. And there's many alternative diagnoses listed in our article that could give you suggestions about what to look for. If it is really refractory ITP, a new set of developments has involved the identification of cytotoxic T cells as having an effect. We had participated in 3 smaller studies, all showing that T cell clonality was associated with difficult disease, but recent work by Nicola Cooper has taken this to the next level and illustrated the cytotoxic effects and how that could be responsible for the refractoriness of the ITP. It's important to mention here that when we think of refractory ITP, the great majority of the current treatments are B-cell and antibody directed. So this may mean that we need to use approaches a little more like those used in aplastic anemia. Now, if you do a workup, there are some things that I call game changers. And these game changers would be things like identifying CMV, identifying cytotoxic T cells, identifying CVID, and a few others. So it makes it appropriate to do the workup, especially the more difficult the case, even if you say, oh, this doesn't look like CMV to me. Remember that a lot of these diagnoses are different in different patients. And if an ITP patient has it and they're not very immune suppressed, you're not going to have fever and a lot of other findings that you might associate with it. There's many things to think about when you're talking to a patient with ITP, again, back to a more typical patient. And these are only some of them, but it's important to consider them and to involve the patient in the decision for what you're going to do if it's in fact needed to do treatment. There are a lot of other non-platelet related things that can help, and they're listed on this slide. They will help as far as bleeding, not necessarily as far as the platelet count. There are many treatments of ITP. IVIG remains the one that's the most likely to bring the platelet count up quickly, and using it with high-dose dexamethasone, IV methylprednisolone is a good way to optimize efficacy and to decrease reactions like, for example, aseptic meningitis. If there's a question of hemolysis, there are preparations that have low titers to anti-A and anti-B. The main things we're going to talk about, at least briefly, splenectomy, rituximab, TPO receptor agonists, and fostamatinib. And then there are some of the newer agents. So we would add dexamethasone in this patient if we were going to do it. And a big issue here is if you use Dex, whether you use it with IVIG or not, sometimes you give it for 40 milligrams a day for 4 days, possibly in the 78-year-old, 20 milligrams a day. And let's say you have a good response in a couple of weeks and the platelets are very good. Do you keep going or not? If your goal is to try to make the patient better more lastingly, I would advocate using 3 or 4 cycles based on the Italian study in blood in 2007. What about this woman? She does well with Dex, but relapses 4 weeks later and doesn't want to repeat it because she hated how she felt. She gained a little weight. Maybe she had some acne, etc. So if there was no COVID epidemic, rituximab would be good because in women of childbearing age who have not had longstanding disease, they have a significant chance, perhaps 50% or even better, of having their ITP not only have a nice response, but to be cured of it, have the response last. On the other hand, in this day of COVID, you don't want to take something that will prevent you from being vaccinated. So you could say, okay, I'll get my vaccines for SARS-CoV-2, and then I'll get rituximab. That's okay, but what if you wanted to get a booster vaccine? This might inhibit vaccine responses for at least a year. So it's important to take that into account. And that's why more and more second-line ITP agents are TPO agents. For fun, these are some cartoons for rituximab here. If you get serum sickness, you would change treatments. You have to monitor for hypogammaglobulinemia, especially if you use dexamethasone, but you should measure IgG levels at the beginning, and you might need to start maintenance IVIG. It's important to realize that if you are hypogamma to start with, that's probably the best prognostic factor for a good response, but it does ensure that you're going to need IVIG or you'll run the risk of sepsis. TPO agents, I think, are fairly straightforward. The newest evidence is that they actually work a bit differently. So if you give somebody one of the TPO agents, romoplastin, eltrombopag, or avatrombopag, and they don't respond, it's not inappropriate to consider changing to another thrombopoietic agent. They may well work, and there's a number of studies initially on switching from romoplastin to eltrombopag or vice versa, and more recently, 2 studies on switching from either of those to avatrombopag. If somebody develops thrombosis while on one of these agents, the most dangerous thing you could do is to stop the TPO agent and anticoagulate them, because then in another week or so, you'll have a fully anticoagulated patient with a very low platelet count. So the best approach is to continue the TPO agent to maintain the count, give appropriate anticoagulation, and then decide how to approach things. Also, it's worth talking about the idea that there are patients who start TPO agents who can then discontinue them and have their count be maintained. It seems that if the count on the TPO agent goes over 100,000, that's more likely to work. But the data that's available is generally close to the initiation of disease. And if somebody has had ITP for 5 to 10 years, I don't think we know what the likelihood is that they could discontinue treatment. Splenectomy is not used very much. It's important to say that if you can hold it for a year from diagnosis and the patient's having a difficult time, it could be included. The main thing that works against it as a long-term therapy, in addition to the lifetime risk of overwhelming post-splenectomy sepsis, is the ongoing long-term risk of thrombosis, which does become significant over time. Finally, fostamatinib is a newer treatment. It may be the one that could be the hardest to tolerate, with issues with high blood pressure and GI side effects. It's particularly appropriate, however, if you have a patient who you think has a predisposition to thrombosis, because it threads the needle of helping to prevent thrombosis while at the same time increasing the platelet count. It may also be particularly good if you have a patient with an inflammatory disease where you want to tone down the inflammation. So in this patient, you would have the advantage of a high rate of cure, but the main con would be the issue of vaccination and possibly the need for IVIG. TPO agents have high response rate. Major side effect is risk of thrombosis, which occurs in ITP anyway. And it's also important to consider that you want to know that she has ITP, because other types of thrombocytopenia might respond, and you can say, hey, that's a good thing, isn't it? But it's also worth considering that that may mean that other issues connected with another disease, other secondary developments will be missed because you won't recognize the disease. I'm going to skip over this except to say that romoplastin has to be given subcutaneously. In the United States, the FDA still hasn't licensed it to be given at home by the patient or a caregiver. Eltrombopag and avatrombopag are oral, but the reason they work differently is that an important mechanism for eltrombopag is to chelate intracellular iron. As a result of this, if it's given with cations like calcium in milk or iron in some form, it will chelate the iron in the diet and be unable to have its effect. Avatrombopag doesn't have those limitations. Less long-term data exists, but it appears to be an extremely effective agent. The adult 63-year-old male is on aspirin, and he chooses a TPO agent because studies have suggested that it's more optimal. And as far as we know, he can take TPO indefinitely, and we don't know, as I mentioned, how long he will need it. We could consider other options. If for some reason the 20-year-old didn't do well with her treatment. She would ideally try rituximab, but could go to a TPO agent. He could try a different TPO if the first one doesn't work. Splenectomy would be much better for her than for him, but ideally you wouldn't want to have to go to that. And there's many immunosuppressive agents as listed to think about. If the patient becomes refractory, combination therapy becomes better and better. Usually want to include a TPO agent. We talked about cytotoxic T cells. Now that T cell clonality can be identified more easily, and one of these agents may be required. So you can keep searching for a silver bullet. Many people, including me, would say, okay, you try a given treatment and it doesn't work, keep going with it and add another agent so that you're getting the benefit of two together. Even if one of them didn't work on its own, it may make the other work better. I'm going to go very quickly over the emerging therapies. The first FcRn inhibitor, efgartigimod, has been licensed for myasthenia gravis, not yet for ITP, but a phase 3 trial has been completed. It will be presented in the plenary session of ASH this year, 2022, and the results look encouraging. A BTK inhibitor designed more specifically for ITP, rilzabrutinib, that doesn't interfere with platelet function, was recently published in the New England Journal, and it also has had very good effects. You would take 400 twice a day, and generally it works pretty well. Complement inhibitors have finally reached the ITP space. I say finally because eculizumab would have been tried in ITP long ago if it wasn't for its prohibitive cost. Current treatments have been with sutimlimab, which blocks C1s and prevents assembly of the C1 complex and thus blocks the classical pathway of complement. That seems to work well in ITP. It works quickly. And there are other inhibitors of complement that are also in use in both ITP, PNH, and other diseases as well that block C3b. So this is rapidly becoming a field where there are a number of agents that may have advantages, either blocking the classical pathway, blocking the alternative pathway, or something like with C5 that blocks both. Finally, there's suggestions that oseltamivir will work. This gets at a mechanism of ITP where it's thought that especially glycoprotein 1b can be desilated, leading to non-immune destruction of platelets in the liver. And oseltamivir may block this, but this remains a setting where the final data is not in. So thank you very much for listening to talking about ITP. Again, just to cover things, it's important to double check the diagnosis, and as time goes on with a patient, keep looking for clues that there's something else going on, whether it's another disease or it's a sign of secondary ITP. Individualized management to suit the patient. That's the flip side of what we talked about in the beginning in the comparison to leukemia. You can treat one patient one way and another similar patient another way. Treatment responses are clues to the pathophysiology. We need more information to allow us to do better diagnosis and better prognosis. You have to walk the line between over and under treatment. In general, for adults, we would say keep the count above 30,000, but different people are different. And what we're lacking is treatments that are not only effective at increasing the count, but are curative. And initially, we thought rituximab would be great there. It seems only to be good and only in women of childbearing age. And we discussed the drawbacks, although we didn't focus sufficiently on the advantages of splenectomy. Thank you.
Thank you very much, Jim, for really a fascinating, fantastic, comprehensive, up-to-date review of the current status about ITP diagnosis and treatment. And I have listened carefully that there will be a plenary at ASH. This is not my cup of tea, ITP, but now, thanks to your advice, I'll go and listen and see what's ongoing. So we have a lot of questions, and this is quite amazing because we are only a couple of days before people start traveling to ASH. So I'll try to structure them into three groups: diagnosis, pathophysiology, and then treatment. So the first question I have for you: is there a threshold of a platelet count where actually you would recommend to do nothing?
That's a good question. I think the several features here. First, you have to correlate the platelet count with platelet function, meaning if somebody has a platelet count of 50,000, but they're bleeding a lot, that's not so good. That doesn't mean it's because of the platelet count, but it means you need to consider what's going on. And some people would argue that you could go down to a platelet count of 20,000. And you may know in pediatrics, the thought is that if somebody has a typical case, even if their platelets are 5,000, if they're not bleeding excessively, most people would now say, leave them alone and see if they get better. So there's not a count. I think the count in general, as I mentioned once, would, if you want to pick a count, it would be 30,000. And if you had somebody on anticoagulation, even that count might be enough, but you might want to be safer and get to 50,000. But it's again, like everything, you got to individualize it. Great question.
I know, and also I remember in the first couple of slides, you used the word that it is art when it comes to ITP management. Okay, we have another question about the role of bone marrow aspirate. Is this something mandatory, or you can skip it in some cases?
More and more, I think, as time goes on, fewer and fewer people would routinely do a bone marrow aspirate. In, for example, the case where you had the woman and her hemoglobin was a little low, so you had 2 lines of cells involved, you could be more confident it was iron deficient because the MCV was low. But if there are 2 lines that are involved, most people would then think about going ahead and doing a marrow. People seem in general in practice to be more easygoing and laid back about that. The question also was about the aspirate. I tend to think if you're going to do an aspirate, unless it's because you're really seriously thinking about malignancy, like leukemia or myeloma, something because you've seen cells in the peripheral blood or have other indications. And again, this is your area, and you know much more about it than I do. Then I think normally you would want to do a biopsy with an aspirate because cellularity would be crucial. And you'd want to know that, and that would, I mean, not that you couldn't do an aspirate and estimate it, but it's better with a biopsy. But yes to doing them, but no, not to doing them routinely. Most people would think you should have a reason.
Okay, wonderful. We have a question. When we speak about platelet count, are we talking about the automated CBC count, or your reference is to rely on the manual count on peripheral smear?
So first of all, it's not really a manual count. It's just looking at the smear. And that can be, as we talked about under artifactual, looking for clumping or something that would make the count low. I have to say that the CBC machines are better at pointing that out to you ahead of time, like, hey, that there are clumps, so that you know you need to look or consider that. A lot of what you're looking at when you look at the smear is morphology, as we talked about. Is there any ongoing hemolysis and so on? And that's to the point where the reticulocyte count, which I've always thought of as the most underused test for red cells, the most underused test in hematology, is kind of been devalued because you can see polychromasia and all that on the smear. Now, what if you're practicing and the CBC is getting taken to a building next door where they have the Coulter counter, instead of having it done right next to you? Then looking at the smear can get to be more of an endeavor. But I think in general, the machines are better and better. So if there's no, we call them flags, at least on the machines I'm used to tell you, hey, there may be an error here, you're probably in pretty good shape relying on the machine count.
Excellent. Thank you, Jim. Let's move to the some of the pathophysiology questions we received. On one of your slides, you have listed an amazing number of drugs that can be involved, and most of them are quite frequently used. But there's one of interest for me in the myeloma field, bortezomib, which is a proteasome inhibitor, which I didn't see on your slide. And historically, I think, remember 22 years ago when we started using bortezomib, that was a major concern to have this cyclic thrombocytopenia. Now nobody cares about it, but what are your thoughts?
Bortezomib has a very delayed form of thrombocytopenia. I mostly left out things that you could consider chemotherapy. But bortezomib's actually been tried, and there have been studies, though limited in ITP, thinking that when you use rituximab and it doesn't work, it's because you're not hitting the plasma cells. And I believe that was the original reason that Francesco Zaya thought, hey, we should add dexamethasone to rituximab. So it definitely can cause, especially a very delayed thrombocytopenia with bortezomib. And certainly a number of chemotherapy agents can be a problem. If you don't mind my interjecting, the recent studies on chemotherapy-induced thrombocytopenia with the TPO agents have been surprisingly disappointing. So what I can say that I think we know so far, and this is for solid tumors, I don't think they seem to work very well in hematologic malignancies. First, if you have somebody whose platelet count is staying low like a long time, like it's more than a month now, and the platelets are still very low, no question in most cases that TPO agents will be helpful to bring up the count. In the setting where you're trying to avoid treatment delays or dose reductions, which is the ideal setting, and where you may even be helping a better cure rate, then the one thing I could say is, and these are studies that Jerry Soft did, using romoplastin, he would administer it weekly, independent of when you're giving the treatment, which is totally not what we do with GCSF, where we wait till the chemo's finished and then we give it. So he gave it weekly in his studies, and it does seem to have an effect. How good an effect, how much it will allow preservation of chemo dosing and timing remains to be seen, and it may depend a lot on exactly which chemo is being used and what the tumor is.
Excellent. Thank you very much. That was very clear. And by the way, I would like to confess that we use a lot of romiplastim and L-Trombopag after allogeneic stem cell transplantation. And I think it fairly works well, but this is not exactly chemo-induced thrombocytopenia. It's more
Right.
like lazy bone marrow, I would say. And
Yeah, I mean, I think that's a very interesting area. There have been a number of studies there, and I think one of the issues is that it's not like one thing, like more or less. If you give chemo and that's why the count's low, you know what you're fighting against. In transplant, could be an infection, could be secondary autoimmunity, could be, as you said, a lazy marrow or a marrow that's just not coming in well. So there's a lot of areas, and those need to be distinguished about using agents. But I agree, the preliminary data, and it's not so preliminary anymore, suggests that that's a setting where it can be quite helpful.
excellent, thanks. One other question about the etiologies and pathophysiology. We have one question from Dr. Vasile. Do you think that immune thrombocytopenia could be secondary to multiple sclerosis? I didn't see on this your camembert.
Right.
And by the way, I must confess that you pronounce your name the French way, Bussel, and I pronounce it the English way, Bussel. You know, this is fantastic. Now I'll say Bussel. It's easier for me.
I didn't put other autoimmune diseases there other than lupus and antiphospholipid antibody. And I should give credit that camembert is from Doug Seams also, though I am an author on the article that described it. I think anytime you have another autoimmune disease, the chances that you could have a second one is increased. One of the things we've gotten interested in recently is that rheumatoid arthritis and ITP seem not to go together at all. And that maybe we're speculating that that's because the HLA underpinnings of it are different. Rheumatoid arthritis is more usually of a DR1 disease, and ITP is more of a DR3 disease. But certainly, if you have multiple sclerosis, you can have ITP. And there's actually a number of years ago, a patient who died because they received, I'm blocking on the name, it's monoclonal that was made in Cambridge originally.
Campath.
Yeah, Campath, thank you. So they received Campath, and then that dropped the platelet count later, presumably because of its autoimmune effects. So I don't know if there's any confusion there, but certainly multiple sclerosis and ITP can occur together.
One question about T-cell clonality, and this is from Dr. Esra Gülderin, who is a young rising star colleague from Turkey. She's very loyal to the ICH webinars, and she's asking about whether you use T-cell clonality as a predictor for response, or is it you check for it when patients do not respond?
That's a great question, and the bottom line is that we don't know. I think Nicola's work, which will be coming out soon in Blood, Nicola Cooper, will clearly, I think, delineate that this is an important factor. But is it something that you have a patient with, let's say, regular ITP, and then something triggers off a clonal expansion so it converts it to refractory ITP, or is it there from the beginning? We don't know. She has followed several patients for a number of years and shown that they maintain their clone, and when the disease is more active, the clone size increases, and when it's less active, the clone size decreases. But the full story certainly remains to be uncovered, and I suspect, or I know, that this is going to be an issue in many diseases and will require a lot of work to sort this out now that we can identify clones much more easily.
Okay, thank you. We have a couple of questions about the use of TPOs, and one question is about whether there is a correlation between thrombopoietin level and response to TPO agonist.
That's a great question. originally, people thought there would be, based on the correlation of degree of anemia with EPO levels. And David Cooter and a rising star, or I think he's a star already, Hani Al-Samkari, who works with him, looked at retrospective data and made estimates for L-trombopag and romoplastin as to how high a TPO level you had at which people would no longer respond. Now, clearly that would be assay dependent, and I'm not certain which assay they use, but I think there's no question if the TPO level is above, let's say, 300 in whatever units, if they're the same as what they saw, you would see a much diminished response. Okay. And by the way, diagnostically, that's also been thought to be something you could use to see if there are megakaryocytes in the marrow or not, meaning the higher the TPO level, the less likely there are to be megakaryocytes, so that possibly in that setting, the lack of response is because there aren't the cells there to respond and make platelets, at least not in the immediate future.
We have Dr. Adler asking whether you have any recommendation or any protocol for tapering TPO agonists.
That's also a great question. And initial studies were not very clear and seemed to suggest, yeah, some people could get off, others couldn't. Whole thing wasn't put together well. Recently, the French group did a study called Stop-A-Go. And what they did that I thought was unusual, and I believe there's now an L-trombopag study that found something similar. If you can give the patient a little more medication to keep their count above 100,000 instead of above 50,000, and then you try to taper, you're more likely to succeed. In the Stop-A-Go study, even though patients had been on romoplastin for an average at least of over a year, they were able to stop 54% of the patients and not have relapses. And the one or two who did responded and then were able to stop again. So I think it may be that keeping people higher would help more. And that's presuming there's some kind of curative effect or whatever of doing that. I would say that a million years ago in the 1980s, the people who did a lot of work with IVIG, Paul Limbach, Adrian Newland, myself, Victor Blanchett, tried to do that anecdotally to see if that would lead to more cure, and it didn't seem that it did, but it was never done very systematically, except for one study from Philippe Bierling, where it did seem there was a little bit of a better effect. They gave IVIG on a schedule independent of the platelet count, and that arm did better than the ones getting it as needed.
One last quick one. Any preference between dexamethasone, prednisone, prednisolone? Because I think you mentioned dexamethasone, and whereas in many European people use prednisone or prednisolone?
The studies that have compared at least prednisone, I'm not sure how often prednisolone and dexamethasone, suggest that dexamethasone will bring up the count faster and may have less side effects, but disappointingly, it's not been clear that it leads to more cures. That was the original reason to use it. And the original study probably should be withdrawn back from the 90s in the New England Journal, but that's a whole other thing. Some people, however, cannot tolerate dexamethasone. And if you give them one cycle and you want to give them another cycle, they pretty much will refuse. So it kind of depends. I think it makes more sense to use dex, but I don't think the full story is in. And it might be that you should be choosing in different patients, and we don't know the parameters yet.
Well, fantastic. I think we need to stop the discussion. I still have many questions about BTK inhibitors, complement inhibitors, et cetera, but I'm sure we'll get you for another, I think, broadcast, Dr. Bussel. It has been a true pleasure. I mean, I have really enjoyed it myself. I hope everybody has enjoyed it. If I have to start a new career, I'm sure I'll go to the ITP field thanks to the enthusiasm and the way you present things. Good. So thank you very much. Thanks to all the colleagues. It has been quite incredible to have so many colleagues attending while everybody's getting ready for ASH. So the ICH activities will continue during ASH, because on Tuesday, and I think you can see it on the screen, the 13th of December, around noon New Orleans time. This is 1 p.m. New York, 7 p.m. Paris, 6 p.m. London. The top experts of the ICH will give you take-home messages in leukemia, lymphoma, myeloma, stem cell transplantation. So please stay tuned. And if you're going to ASH, safe travels. If you are still around, wherever you are, please stay safe and keep well. Take care. Thank you, Jim, and hope to see you soon.
Thank you.